should be your top concern. Start with a thorough history, focusing on the nature of the pain, which you may have been suggested to use something like Socrates to investigate via your history. This will determine whether it's crushing, pressure-like, or radiating to the jaw or left arm. Remember that ACS can present atypically, especially in women, the elderly, and in diabetic patients. In terms of investigations, of course, perform an ECG, and this should be ideally done within 10 minutes of arrival. Look for signs of ST elevation and new left bundle branch block, or T-wave inversions. Serial ECGs and monitoring are crucial as changes can evolve. This we would typically term as a dynamic change on ECG. Obtain cardiac biomarkers, primarily troponin, which will suggest potential myocardial injury. Equally, you will usually perform serial cardiac biomarkers as well, especially if the first is raised to some reasonable degree. Management: administer aspirin immediately unless contraindicated, along with oxygen if hypoxic, although in some cases and some areas this is administered regardless of hypoxia. Nitrates for pain relief, such as GTN, and morphine if needed. This is typically termed as the MONA or MONA management for ACS. For STEMIs, immediate reperfusion therapy with PCI is essential. In a non-STEMI or unstable angina, initiate dual antiplatelet therapy and anticoagulation, while arranging for further risk stratification and management. This should give you a fairly concise approach to ACS in general. And as we go through each of these topics, it's important to note that management will change on the specifics of the cases. Next up, let's talk about pulmonary embolisms. As an approach, PEs should be suspected in patients with sudden onset pleuritic chest pain, dyspnea, and risk factors such as recent surgery, immobilization, or malignancy. Start with a D-dimer test in patients with low to moderate risk to rule out a PE. High-risk patients should go straight to imaging with a CT pulmonary angiogram or a CTPA, which is the gold standard for diagnosis. Ordering CTPAs in patients with suspected PE can be challenging in the clinical environment and the workplace. As a new doctor, especially in the UK from my experience, you will find that radiologists will often rebuff your request for a CTPA. A key thing to clarify is the Wells score, and whilst this may sound silly, do not follow the guidelines too strictly. You are essentially, when talking to the radiologist, trying to convince them. It's essentially you remember that you are the patient, you are the doctor who has seen the patient. If you suspect a PE, it is down to you to convince them that they need the appropriate investigations. The radiologist cannot see the patient and is only going off what you say and your clinical urgency. There have been several occasions in my own experience where I have maybe bent the truth very slightly in order to better convince and get through my CT request, and I'm glad that I did so in those situations. Just to put it in a somewhat diplomatic fashion. But anyway, in terms of management of a PE, once confirmed on CTPA, you can begin anticoagulation. Actually, that's not quite true. You should begin anticoagulation immediately after being suspected, to be honest, especially if you cannot wait for the results of the CTPA. Now, typically, anticoagulation is given, especially low molecular weight heparins, are administered at about 6 p.m. on the wards, and so your decision to anticoagulate, unless there are specific reasons why this may not be the case, so case by case as always, you could in theory wait until that time to make your decision in terms of anticoagulation. Perhaps you can wait for the CTPA until then. However, if it's getting towards that time, or it is in the evening or something, then you probably best just to get on with it and prescribe the anticoagulation as per the guidelines. As I said, this can be low molecular weight heparin or a direct oral anticoagulant for massive PEs with hemodynamic instability. Thrombolysis may be necessary, and that would also play into the timing of your anticoagulation as the urgency is much, much higher. Finally, aortic dissection. You should consider aortic dissection in patients presenting with a sudden, severe, tearing chest pain that radiates to the back. A history of hypertension or connective tissue disorders like Marfan syndrome serves to increase the suspicion of a diagnosis. A widened mediastinum on a chest X-ray can be a clue, but a CT angiogram of the chest is definitive for diagnosis and most certainly the gold standard in this case. To manage this, blood pressure control with IV beta blockers is critical to reducing shear forces on the aorta. Type A dissections, which involve the ascending aorta, require emergency surgery, while type B dissections may be managed medically until complications arise. Now that concludes chest pain, so let's move on to shortness of breath. Shortness of breath or dyspnea is another common and potentially life-threatening symptom that presents in a variety of ways, demanding prompt and careful evaluation in the emergency department. Let's start with probably the most common thing you will ever see in the hospital, which is chronic obstructive pulmonary disease, COPD, plus or minus asthma. The algorithms for dealing with and COPD based on patient history. Asthma typically presents in younger patients with a history of atopy, while COPD is associated with long-term smoking and presents in older adults. Important to remember, just as we go through these, I will keep reminding you, but these are pretty simplified and generalized approaches. Asthma can absolutely present in old adults. Although COPD, you'd be pretty hard pressed to find in anyone below a certain age, really. In terms of investigations, you should check the peak expiratory flow rate for asthma exacerbations and use spirometry to assess lung function in COPD. A chest X-ray may help to rule out pneumonia or pneumothorax. It's important to remember again that in the ED setting, as somebody on the emergency team, things like spirometry and lung function tests, these are not going to be a decision that you make, but it's important to know them as part of the treatment pathways and investigations for these conditions. In terms of management for asthma, start with inhaled bronchodilators like salbutamol or ipratropium bromide, along with systemic corticosteroids, depending on the severity. In severe cases, consider magnesium sulfate and non-invasive ventilation. COPD exacerbations are treated similarly, but often include antibiotics and non-invasive ventilation for hypercapnia. Now let's talk a little bit about congestive heart failure. You should suspect congestive heart failure in patients with shortness of breath, especially if they have a history of heart disease. Look for orthopnea, paroxysmal nocturnal dyspnea, and peripheral edema. These are all key flags that you should have in your mind when investigating and suspecting potential heart failure. A chest X-ray may show pulmonary edema, cardiomegaly, and pleural effusions. BNP levels can support the diagnosis, and an echocardiogram is useful for assessing cardiac function. In terms of management, administer oxygen. Diuretics such as, and almost always, furosemide. Add vasodilators such as nitrates to reduce preload. And ACE inhibitors and beta blockers can be used in chronic management, but acute decompensation requires careful hemodynamic support. It is often a tricky balance, and it takes very careful consideration and senior input to balance hemodynamic instability along with fluid overload in these patients, especially those with advanced congestive heart failure. Pulmonary embolism is also something that can be and is very, very frequently associated with shortness of breath. It's usually a case of ruling out everything else before considering, unless it's blatantly obvious, really. But refer back to the previous section for approach investigations and management on that condition. Let's talk a bit about abdominal pain now. So, abdominal pain is a broad classification of a symptom with a wide set of differentials requiring a careful and thorough approach, as really can range from the not very serious to the crucially serious. You should suspect appendicitis in patients with an acute onset of pain that starts in the periumbilical region and later localizes to the right lower quadrant. Associated symptoms include anorexia, nausea, and low-grade fever. On physical examination, you may reveal tenderness at McBurney's point, guarding and rebound tenderness. Ultrasound can be used initially, but CT abdomen is the gold standard for diagnoses of appendicitis, and in fact all surgical conditions suspected under the sort of heading of abdominal pain. If you have any kind of surgical concern, a CT abdomen is the gold standard. Usually requesting this and getting that through is done by the surgical team, although I'm sure they'd be very appreciative of you if you have a high level suspicion and you get that put through before they come and review, at least from my experience. To manage appendicitis, this is a surgical emergency, so the patient needs surgery. The patient should be nil by mouth, started on IV fluids and antibiotics, or before surgery. When the surgery occurs, it is of course a stratification of risk, and so it's important that all these are started as soon as possible, really. Another consideration is cholecystitis. This should be considered in patients with right upper quadrant pain, especially onset after the ingestion of a fatty meal or food. It often radiates to the back or the shoulder, presenting with a fever and Murphy's sign, which is pain on palpation of the gallbladder. These are all super key findings for considering cholecystitis. An abdominal ultrasound is the investigation of choice initially, as this may reveal gallstones and gallbladder wall thickening. If the diagnosis is unclear, a GI-DA scan can be used, but once again, given the list of differentials, a CT abdo exam is somewhat gold standard to a degree. To manage this, IV fluids, analgesia, antibiotics. However, if there are gallstones which are causing repeated bouts of cholecystitis, or if the episode of cholecystitis is particularly serious, then early cholecystectomy is the definitive treatment. Early cholecystectomy, did I say early cholecystectomy? Or early cholecystitis, I'm not sure. Basically the removal of the gallbladder. Next up, let's talk about peptic ulcer disease. These can cause epigastric pain, that is burning or gnawing, often relieved by antacids, but may worsen after meals if the ulcer is gastric in nature. Look for signs of complications like hematemesis or melena. To investigate, endoscopy is the gold standard for diagnosis, but in the acute setting, an upright abdominal X-ray can help to identify perforation by showing free air under the diaphragm. To manage this condition, start with PPIs and consider testing for H. pylori. In the case of bleeding ulcers, endoscopic intervention may be needed. Now, this is going to be a really important one for ED, but let's talk now about trauma. Trauma cases in the emergency department require rapid assessment and intervention. Here's how to approach some of them. Of the most common in nature. Head traumas can range from mild concussions to severe traumatic brain injuries. You should evaluate for a loss of consciousness, confusion, vomiting, and amnesia. Utilising the Glasgow Coma Scale, or GCS, is essential for assessing severity. A non-contrast CT of the head is the first line investigation to rule out intracranial hemorrhage, fractures, or brain swelling. And for minor head injuries, observation and symptomatic treatment are often sufficient. Severe cases of head trauma may require neurosurgical intervention, particularly if there is evidence of increased intracranial pressure or hematomas. Let's talk a bit about fractures. These are common in trauma in the ED setting. Look for pain, deformity, or inability to use the affected limb. Open fractures require immediate attention due to the risk of infection. X-rays are the primary imaging modality for diagnosing fractures. In complex cases, CT scans may be necessary to assess the full extent of the injury. When managing fractures, you should look to immobilize the fracture with splints or casts, administer analgesia, and consult orthopedics for possible surgical repair. Open fractures require tetanus prophylaxis and antibiotics. It's also important to have good joint manipulation and management in these cases. Abdominal trauma can be considered as blunt or penetrating, and it can damage internal organs like the liver, spleen, or intestines. Suspect internal bleeding in patients with hypotension, tachycardia, and abdominal tenderness. Perform a focused assessment with sonography in trauma or a fast scan to detect free fluid. The CT scan with contrast is the gold standard for evaluating organ injury. To manage these hemodynamically unstable patients with evidence of significant intra-abdominal bleeding often requires urgent surgical exploration. For patients who are stable, managed conservatively or surgically based on the extent of injuries. Now, sepsis is another one that we need to go through. It can sometimes be looked on in a time when you start working. It can become a little bit tiresome when you, as a clinician, do not suspect sepsis and you have to engage in the Sepsis 6 bundle. But remember that its correct application is critical to the appropriate management of patients with sepsis. And so I would grin and bear it in many of these cases. So the Sepsis 6 bundle: administer high flow oxygen, take blood cultures and give broad spectrum antibiotics, start IV fluids, measure serum lactate and monitor urine output. This is typically remembered as give 3 and take 3. So you give oxygen, you give antibiotics and you give fluids. Whereas you take blood cultures, you take a blood lactate or serum lactate, and you, take urine output. So you monitor what's coming out, and you give 3 things. Next up, patients with septic shock may require vasopressors and intensive care support, but this will really only be suggested with the careful input of the ICU team. That is sepsis, and that is all of the conditions that I wanted to talk about in this video. So that concludes our overview of some of the most important topics you'll encounter in the emergency department, from chest pain and shortness of breath to trauma and sepsis. These scenarios require a blend of quick thinking, thorough investigation, and effective management. I hope this video has provided you with a clearer understanding of how to approach these conditions. If you found the video helpful and would like to see more content like this, please do consider subscribing to the channel and leaving a comment below along with a like. I'd love to hear your thoughts and suggestions for future medical